This is Dr. Howard Strassler presenting the e-lecture Anterior Aesthetic Preparations and Restorations, Module A, the Class 5. And you can see from these images that the Class 5 is at the cervical third of the tooth, and that our preparation design is defined by the extent of the carious lesion, as you can see in the center picture. And then our attempt is to restore the restoration with a composite resin that picks up the color of the adjacent tooth structure so that it's not visible to anyone that a restoration has been done. So let's talk about the preparation and restoration of Class 5 lesions. Class 5 lesions can be carious lesions, as we can see as we see in the images to our left, the Class 5 carious lesions on the premolars and on the mandibular first permanent molar. And you can see on the first permanent molar that this was a lesion of neglect. You can see the demineralization, remineralization at the cervical third of the first molar. In fact, when it remineralizes with a discolored appearance. That's hard and shiny on that surface. Or in the case on the right, where we see a Class 5 lesion on the cervical third, in this case on a maxillary first permanent molar in the lingual, and that we've had recession. We can see some loss of tooth structure due to probably erosion, abrasion, and in fact there's a carious lesion forming in the central portion of this non-carious cervical lesion, initiated through erosion and abrasion probably, but now it's become carious. And so you know the definition already of a Class 5. Smooth surface caries or non-cervical carious lesion at the gingival third, either the anterior or posterior teeth. It can be either on the facial or lingual surfaces. So let's go through the clinical technique. And we're going to look at several different clinical scenarios and restorative materials. We're going to look at placing a composite for a carious lesion. Using a dental dam, we'll look at placing a composite for a non-carious cervical lesion. We'll look at placing a composite using packing cord to gingivally retract where a dam would have been difficult to apply. And we'll talk about using resin-modified glass ionomer to restore a Class 5 carious lesion. Well, we're doing an aesthetic restoration, so we make our shade selection before the application of the dental dam, before tooth preparation. That's when we're selecting the shade. We're basing the shade on the color of the area being restored. And keep in mind, the composites we use are typically translucent. They'll have a chameleon effect to match the adjacent tooth shade. And in fact, our preparation design on enamel with the bevel allows us to establish not only additional retention because of more surface area to bond to, but also gives us a better aesthetic blend of the composite. When we're choosing shades, we're going to use a shade guide, and here we're looking at the TPH3 shade guide, and it's packaged in the clinics that we would go to Prep Dispense and request that shade guide. You can see that as we look at the designations on the shade guide, that these designations are done two different ways. One by description, using some of the Vita shades. You can see B1, A1, C1, but also they're using designations that are not on the typical porcelain shade guides. Here we see LG for light gray, LYG light yellow gray. We move over, we see DB for dark brown, DY for dark yellow, and then their darkest shade, extra gray brown, XGB. There are opaque shades. Here we see a C2 opaque shade on the right hand side. And so we're going to select a shade in the area of the tooth that we're restoring. There are other shade guides that we can use in the clinic. We have a nano hybrid, micromatrix hybrid composite aesthetics, and it has its own shade guide, or we can use the VitaPan Vita original shade guide, which And here we're seeing a shade guide for Vita on the bottom. This one is actually put together being value ordered, where B1 on the left-hand side is the lightest shade of value, all the way up to C4, which is the darkest shade. Our cavity preparation design, whether it be on the lingual or facial surface, when caries is present, we'll be doing a very definitive preparation, that the outline form will be defined by the extent of the lesion that we're restoring, and our typical burrs of use are either a 330 burr, which is a pear-shaped burr, or an inverted cone burr, a 33.5 to a 37. In the clinic, we're typically using a 35 for instrumentation. Whenever possible, we're going to use a dental dam. We're going to place the dam after we've administered anesthesia. For a class 5, in many cases, we need to use specialized retainers, gingival retraction retainers, either a 212 or an ivory number 9. But there will be time when dam placement will compromise the soft tissue, may cause bleeding. In those cases, we're going to use gingival retraction cord to control and retract the soft tissue and keep it as well isolated as we can. Our preparation is going to be defined by the carious lesion, and you can see on tooth number 8 on the left-hand side, on the top, we can see the carious lesion, and you can see this carious lesion is subgingival. We're going to do our preparation design based upon the extent of the caries, and as we look to the top right, we can see we've placed a 212 gingival retraction clamp. You can see how it's moved the soft tissue away from the outline. We can visualize the gingival margin of the preparation. We've removed all the caries in this very deep cavity preparation, and that preparation was defined by the carious lesion. For this circumstance, we in fact place a liner in this deepest area. Okay. When will you not even attempt to use the dental dam? When will you be very cautious? Keep in mind the composite resins we use are hydrophobic. We don't want contamination in the field. While we can place amalgam where there may be some hemorrhage and some saliva and still get success, with composite, we really significantly compromise the restoration. And so when you're in clinic, many times you might want to be using the dental dam, and a faculty member will look and say, you know, this is a circumstance where placing a dam is going to be very difficult and in fact may cause gingival bleeding. It'll put the restoration at risk, so we're going to say let's isolate it different ways, or we'll have you place the dam after the tooth preparation because of the circumstance. So for the class 5, we want to be careful not to abrade the gingival tissue. We don't want any bleeding. We might place it either before we start the preparation or after the preparation, and we may place gingival retraction cord to control the soft tissue and control bleeding. When we place gingival retraction cord, we're careful to avoid any trauma to the gingival tissue. We don't want the placement of the cord, in fact, to create the gingival bleeding. And we talk about gingival bleeding, that also relates to when we're doing our cavity preparation. We want to make sure that we don't lacerate the gingival tissue with the burr, and in fact the recommendation for a 35 inverted cone burr relates to its length. It's half the length, about half the length of a 330 burr, which means that it'll be totally within the cavity preparation. A number 2 and number 4 round burr would accomplish some of the same things as the inverted cone. 330 burr, its length at the gingival margin, if it's subgingival and you've only placed cord, may actually nick and lacerate the gingival tissue. Here we're looking at 2 examples of placing gingival retraction cord. When placing the gingival retraction clamp, gingival retraction retainer is not possible. We can see that the caries is at the gingival margin. uh, of these two clinical situations, and placing the gingival retraction cord, and it's very obvious on the lower right hand side that placing the cord has moved the soft tissue out of the way. And what I want you to notice, the cord's been placed very firmly with a thin instrument sliding it subgingival, and in fact you'll notice the cord is not sitting at the free margin of the gingiva, but it's been actually tucked into that cuff, into that gingival sulcus. So we're doing our preparation. Well, there are certain considerations for preparation design for Class 5s. Keep in mind, Class 5s are in non-stress bearing areas, and so we can bevel the enamel margins. If the margins are totally in enamel, our bevel is going to be 45 degrees. It'll be half to 1 millimeter long, half the thickness of the enamel. And here we're looking at a cross section of the tooth facial-lingually. And this bevel's been placed. We can use a large round burr to place the bevel. We can use a flame-shaped burr to place the bevel. Keep in mind, this bevel of the enamel does several things. The enamel rods are left more exposed, so we have more and better etched enamel. We have better retention because we're creating more surface area to bond to, and because the composite's translucent, that bevel is going to create a blend between the enamel of the composite placement to inside the cavity preparation. That'll create a chameleon effect so that the composite is a better color match to the surrounding tooth structure. When we have our gingival margin on the root, whether it be a non-carious cervical lesion, a notched lesion, or it's a carious lesion, we're still beveling enamel where enamel is present, using that same principle of 45-degree angle, half to 1 millimeter long, half the thickness of the enamel. But on the root surface, we're going to leave it as a right angle margin. We're not going to bevel. It offers us no advantage to bevel a margin on a cementum, on a dentin, on a root surface. Well, when these non-carious cervical lesions become very, very deep, we in fact can place a retentive groove with a half or quarter round burr. And when we're placing the retentive groove, unlike when we do it for our typical cavity preparations, trying to keep it all in dentin, it has to be in dentin. There is no DEJ, and so this notch is actually placed halfway between the cavo-surface margin on the cervical and halfway between the axial wall. Keep in mind the reason for doing that is as we get further down on the root surface, we're closer to the root canal. And so we want to not put that pulp at risk, and we create our notched lesion sort of halfway with a half or quarter round burr. So here we're looking at a preparation design where the carious lesion ends on the root surface and the enamel. If we look at the cervical margin, we have a right angle margin. That's what's been created with our burr, whether it be a 330 burr or a 35 inverted cone. Our enamel margin has that 45-degree angle bevel, half the thickness of the enamel, and this bevel is between half and 1 millimeters in length. For our non-carious cervical lesions, if we take a look at the first and second premolars on the left-hand side, that our preparation's been defined by the notching, the non-carious cervical lesion, and we've beveled the enamel, and we've made enamel our primary retentive tooth structure because we'll be etching it, and these bevels are about 1.5 to 2 millimeters in length. We've freshened up the dentin surface with a round burr so that we're creating a fresh smear layer. It removes any calculus, any debris, any pellicle that's gotten on that dentinal surface, and for this case, because of the depth, we've created gingival retention with a quarter round burr before restoration. And here we're seeing a blown up view of those preparations, and you can see the gingival retention is halfway between the cavo surface margin and the axial wall created with a quarter round burr. So let's look at the clinical technique to restore a non-carious cervical lesion using a single component adhesive using composite resin. And keep in mind, this is a review of what you've learned in the first year operative curriculum, and it's looking at a variety of different cases and how they're being managed. And so here we're seeing a non-carious cervical lesion that the patient's unhappy with the aesthetics of that gingival area, and there's some sensitivity. The enamel's been beveled, and this enamel bevel's around 2 millimeters long to get a better aesthetic blend. The dentin's been refreshed, and you can see that a cord's been placed in the cervical, and that the cord is placed subgingival. I placed the cord to show you an example of how the cord retracts the gingival tissue, and we'll then also see with the dental dam for that case. For all of our adhesive restorative procedures, we're going to be doing the same thing. We'll be etching the enamel and dentin simultaneously. We'll be using an adhesive, and it can be a single component adhesive like the Optibond Solo Plus, or it can be a multi-bottle adhesive like the Scotch-Bond Multipurpose. And then we'll be placing our composite resin, and we'll be using the TPH3 as our nanohybrid micromatrix hybrid composite resin. Our etchant, and the etchant we use in the clinic, is about a 35% phosphoric acid, although there are different ways that it's applied and placed. We can place the etchant with a brush, or we can do needle tip dispensing. Typically we're doing needle tip dispensing with a 35% phosphoric acid, and it's blue in color, and it's in a gel formulation. The adhesives we're using at Maryland are either a multi-bottle adhesive, and on the top you can see Scotch-Bond Multipurpose, which has a separate primer and a separate adhesive, although our primary adhesive for direct placement composites is Optibond Solo Plus, which is a unit dose dispensing that will be taking from the little unit dose container using a brush. At the current time, we're not using self-etching adhesives at the University of Maryland. The materials that we use for the adhesive procedure, we're just reviewing the chemistry of the adhesive. That the multi-bottle 4th generation adhesive, Scotch-Bond Multipurpose, has a separate primer that has organic solvent, in this case an alcohol, some have acetone, a hydrophilic monomer, HEMA, hydroxyethyl methacrylate, and the adhesive has a bis GMA resin plus the hydrophilic monomer, HEMA. Our single component 5th generation adhesive contains the primer and adhesive all in one, our organic solvent, our hydrophilic monomer, and our bis GMA resin, and just a little bit of water. And here we see examples of the products we're using at University of Maryland. Our 4th generation product, Scotch-Bond Multipurpose, and our 5th generation product, Optibond Solo Plus. We're going to be etching the enamel, and the purpose of etching the enamel is to clean the tooth surface, increase surface area by creating etched enamel rods that's giving us a rougher surface, and we're also increasing surface energy, allowing for better resin penetration of this microscopically roughened surface. Before we start our clinical technique, the tooth needs to be clean of all calculus, all pellicle, all stain. We can do that with a prophy cup and prophy paste, or a prophy cup and a paste of pumice that we create. And the way we create a paste of pumice is we take some pumice from the lab, put it in a paper cup, add a little bit of water. It'll be way too liquidy and not very abrasive at this point. We then take a cotton roll and put it into the cup and just soak up any extraneous water, and then we have a very viscous paste. We use that paste on a rubber prophylaxis cup to clean the tooth. We always want a clean tooth surface to etch and to bond to. Here we're looking at, on the right hand side, what the etched enamel looks like, and you can see that we've etched the interior surface of the enamel rods, creating a microscopically roughened surface that in fact looks like carpeting. For The enamel dentin, when we prepare the tooth, we create a smear layer. The smear layer becomes much more critical to remove on the dentin itself, and the smear layer by definition is the layer created by rotary cutting instruments. It's made of loosely bound debris, collagen hydroxyapatite crystals, and in fact the smear layer actually plugs up the dentinal tubules. Between each of the dentinal tubules is a structure of dentin that we refer to as peritubular dentin. So let's take a look at how the enamel cleans the enamel surface and removes the smear layer from the enamel and dentin surface. So that we place the etchant on, and typically our rule of thumb for prepared enamel is 15 seconds of etching of enamel and dentin, and that we can see our enamel appearance on the lower left-hand side looking like carpeting, microscopically roughened, and our dentin on the upper right-hand side, we can see this smear layer, this loosely bound debris on the dentin. We etch the dentin for 15 seconds, and now you can see the dentin has exposed dentinal tubules, and you can see that the peritubular dentin, in fact, looks very porous. This porosity of the dentinal tubules and the peritubular dentin will give us our best result. And here we're taking a look at a tooth, a class 4, where we're applying the etchant to the tooth, etching the dentin, and etching the enamel. The evidence of based upon the current research of enamel and dentin shows that for prepared enamel, we would etch prepared enamel 15 to 30 seconds. Normal dentin in a younger individual up to the age of 55, we'd etch the dentin for 10 to 15 seconds. For older adults over 55 years of age, we should be etching this sclerotic dentin for 30 seconds. So for this case, that we've already done our preparation, freshened up our dentin with a round burr, beveled our enamel, and here you can see a gingival retraction clamp in place. We're etching the dentin for 15 seconds and the enamel for 15 seconds. Even though we don't have a scanning electron microscope to look at this enamel and dentin, it'll have that classical appearance of a carpet-like micromechanically roughened enamel surface. When we remove the dentin smear layer, as we can see the smear layer on the lower left-hand side, that we'd leave the dentinal tubules open, and we'd leave the peritubular dentin looking like ready to soak up, almost like a sponge, the adhesive as we place it. We rinse the etchant off the tooth for 10 seconds with either an air water spray or a water spray. We can blot the enamel and dentin with a cotton pellet, keeping the dentin moist but leaving the enamel bone dry and frosty in appearance. We apply our 5th generation adhesive to the enamel and dentin, leaving it on the enamel and dentin for about 5 seconds, and for that 5 seconds we can agitate the brush on the surface. We're then going to take air spray and evaporate off the organic solvent. In this case, for Optibond Solo Plus, we're evaporating off the alcohol. We're air thinning the adhesive so that it's a very thin layer, and then we're going to be light curing. And so our adhesive will penetrate the peritubular dentin, the dentinal tubules, creating what's referred to as a hybrid zone. And the SEM that you're looking at on the lower left-hand side is the undersurface of the adhesive. We've taken dentin that we've applied adhesive to, and we've dissolved all the dentin. Once we've dissolved all the dentin, you can see only the resin remaining, and you can see how the resin penetrates the dentinal tubules with those finger projections that the adhesive gets within the peritubular dentin at a microscopic level, and then we would restore it with composite. For this composite, when we place it, we have a C factor of 1, no need to layer it. When we talk about placing composite in layers and increments, we refer to the fact that the number of cavity walls, preparation walls, has an impact upon polymerization shrinkage. A class 5 has only one wall, the axial wall, and so there's no need to layer. And here we're placing the composite using our compules and our gun. We're placing it on the facial and then using a plastic filling instrument, a PFI, that we've wetted with some of the adhesive, and we're adapting the composite to the tooth. As we're adapting it, we're trying to end up with very little excess so that finishing and polishing will be very minimal. We've light cured the adhesive, placed the composite, and now going to light cure the composite resin. We want to make sure the light guide is as close to the tooth as possible, at right angles to the preparation, and we're going to light cure for 10 to 20 seconds, depending upon the thickness of composite, the shade of composite. You'll be getting a separate e-lecture on light curing that'll speak to the need for energy for light curing. So there's no need to layer because we have a C factor of 1. The composite's been placed, and I'm going to go back a slide. Look how minimal the excess is for this composite after light curing. The only area that is going to be a little bit more difficult to restore is if you look where the gingival retraction clamp is. The composite is a little bit thicker in this area, in fact has a slight overhang. That is very typical when we use a gingival retraction clamp. If we're using cord, we can end up adapting the composite at that gingival margin much closer and have less excess. So we're going to finish the composite resin. We're going to take the instrument that's appropriate to the tooth surface restored. The finishing is going to be the same for all types of composites in terms of what we use, going from coarsest to fineness abrasive. And this is a review of what you did in your first year when you were finishing composite resin. Our gross finishing is going to be done with finishing diamonds and finishing burrs. In fact, here we're looking at finishing burrs that are needle shaped, and on the right hand side you can see one that has an egg shape. We can also use finishing diamonds, and in the kit we use in the clinic we do have some finishing diamonds that are flame shaped, and we have a finishing burr that's also flame shaped and parallels that finishing. After we've finished our gross contouring, we can then use rubber abrasives, and we can use our enhanced finishers. For the class 5, the cup shape is the optimum shape to use, as we can see in the clinical image on the upper right hand side. The cup shape really fits to the tooth and shapes the tooth in this area. To marginate the incisal margin of a class 5, we can use medium and coarse discs to marginate against the enamel. Unlike in preclinical with your ivorine, with your plastic teeth, the finishing discs would basically finish the tooth faster than the composite. Enamel is very resistant to abrasion by these discs. When we're using the cup shape, when we're using the enhanced silicone aluminum oxide abrasive finisher, we're going to run it at a speed, a minimum of 10,000 RPMs. Know your handpiece. We never place polishing paste in the enhanced cup. If we want a higher luster, we use the composite polishing paste in a prophy cup. So never place polishing paste in the enhanced cup shape. The enhanced polisher, this rubber silicone material, is impregnated with an aluminum oxide so that it'll abrade the composite besides polishing it. When we're using soft flex discs, we're going to go from coarsest disc to medium disc to fine to superfine grit. And what's key to using this disc system is to always wipe off the grit from the tooth, from the composite, with a damp cotton roll between each of the different grits. The finest polish will be with our superfine grit soft flex disc. Running it at between 10 and 15,000 RPMs, leaving it on the tooth surface for 5 seconds at a minimum, running it at that high speed. And the discs fit on a pop-on mandrel, and the pop-on mandrel can either, depending upon the shank that you use, fit either to the latch handpiece or to the friction grip. If you're using the friction grip electric handpiece, it's critical that you not run the disc on the 40 mode. The 40 mode is 200,000 RPMs and puts the tooth at risk with the friction grip 5-to-1 angled head. So we're marginating the occlusal margin, the incisal margin, with our discs, and then we polish it. Here we're using a superfine soft flex disc for polishing a class 4. And we're looking on the lower using a foam cup or a Profi cup using a composite polishing paste to get our highest luster. So let's marginate with a needle-shaped diamond. In our clinics we have a fine-shaped, flame-shaped diamond, a red striped diamond for marginating this gingival margin. You can see the cord is still in place. The gingival retraction clamp has been removed, and we've moved the cervical margin away from the soft tissue to give us access. When we finish a class 5, it's not unusual to have hemorrhage and bleeding in that area. I'm going to marginate the incisal edge using in this case I'm using a medium grit soft flex disc on a pop-on mandrel. My final polish of the composite is then going to be with a superfine soft flex disc. In between the medium disc and the superfine, I can be using the enhanced silicone aluminum oxide polisher, running it at least 10 to 12,000 RPMs using the cup shape. Our initial presentation on the upper right-hand side, upper left-hand side, and our finally finished composite. And you can see we've removed the cord, and the gingiva is just a little beat up. That is very common when placing a class 5 restoration. In this case, we're looking at a pre-op and post-operative view of a very deep class 5 non-carious cervical lesion, an NCCL, and that at the cervical third, especially older patients, the composite shade is going to be darker than at the middle and incisal third. In fact, typically when restoring class 5s, I start with looking at A3 as a shade, or A3.5. This preparation is going to have my occlusal bevel on the premolar, and at the cervical third I'm going to create a retentive groove because of its depth. I place my composite using a etch adhesive composite placement, which is the same for all our restorations, to get an invisible restoration that's restoring that cervical third. For this case, a clinical case where I'm placing a class 5 carious, restoring a class 5 carious lesion, and you've seen this before last year, that the caries is tacky and sticky to my explorer. I place a gingival retraction clamp. My 212 clamp is placed. My preparation is defined by the extent of the caries, and I can use a number 2 round burr and a slow speed. In fact, class 5 lesions can be prepared almost universally with slow speed handpieces only. When the caries is removed, the dentins hard and resists explorer penetration. I bevel my enamel margins with a round diamond or a beveling diamond, as you see here. And then I'm ready to etch. I etch the enamel and dentin simultaneously for 15 seconds. The tooth is thoroughly rinsed with a water stream or an air water spray for 10 seconds, and I'm using an HVE, a high velocity evacuation tip, to remove the water. The enamel has a frosty appearance, and I'm always etching beyond the enamel cavo surface margins. I want the adhesive to be there, and I want to be on etched enamel. If I'm on unetched enamel and I don't finish the composite back to the tooth structure, I'm going to make an area susceptible to marginal staining and microleakage. The dentin should be slightly glossy, not dehydrated. with no visible water present, and the enamel should look frosty in appearance. I then can apply Scotch-Bond multipurpose, applying the primer to the dentin and enamel surfaces simultaneously with the adhesive. In this case, I'm using Scotch-Bond multipurpose and not Uptibond solo. So here's my primer. It's applied to the enamel and dentin and then air dried off after sitting on the surface for 5 seconds. I'm evaporating off the solvent. I then apply my adhesive from the Scotch-Bond multipurpose, keeping it very thin, taking air to air thin it, and then I light cure it, keeping the light at right angles as close to the tooth as possible, and light curing for 10 seconds. I apply my composite resin, in this case increments no greater than 2 millimeters because now I have a cavity preparation. This preparation is 2 millimeters in depth, so 1 increment will do the trick. I squeeze the composite into the preparation. I minimize excess. I use my PFI instrument to adapt it. I wet my PFI instrument with a little bit of adhesive so the composite isn't sticky to the instrument. If I had a deeper preparation, I'd place the increments no greater than 2 millimeters in depth to minimize polymerization shrinkage. I've shaped the composite with my PFI. I then am light curing for 20 to 30 seconds with the light as close as possible to the preparation. And in this case, I'm limited because of the gingival retraction clamp. I'm then going in and light curing with the light at right angles as close as possible. I'll actually start the light a little bit further away and then move it closer. I'm going to make sure there's an orange shield, so I'm watching where the light is, and I'm stabilizing the light with a finger rest on the tooth. I want to make sure I'm positionally where I want to be when I light cure. I'm going to finish the composite using the same instruments that I used previously, using my Softflex discs after I've used my finishing burr, and then my final polish with a polishing paste. So I've used my finishing burr to remove excess. I've used my Softflex discs. Now I'm using my enhanced cup shape to do some finishing and marginating, running it at above 10,000 but under 15,000 RPMs. I never put my polishing paste in this cup shape of the enhance. And then I polish it with my composite polishing paste. Here I'm using a buff cup, but you can use a Profi cup. And here we're looking at the preoperative view on the left-hand side of the carious lesion, and then the composite restored, restoring that carious lesion in a postoperative view. Let's take a look at replacement of a defective restoration. We've looked at restoring a non-carious cervical lesion. We've looked at restoring an initial carious lesion. Well, in this case, the patient already has a composite resin on this tooth, on this maxillary canine, but we can see caries around the facial mesial margin. In fact, is this recurrent decay or is this initial caries that's been formed? We're going to call this recurrent decay because it does extend to the margin. It may have initiated at the margin of the restoration and now has just stayed there and expanded. In this case, we're isolating it with gingival retraction cord. The cord's been placed so it's slightly subgingival, and you can see, whereas before I couldn't see the root surface margin, now I can see the root surface margin, and I have greater room in order to prepare this class 5 restoration. I'm going to remove all the composite and prepare the caries. What I don't know is how far the composite extends. A radiograph won't show me that. And so when we go in, we're going to remove all the composite to see the tooth structure. There'll be times that we will leave composite and cavity preparations, and you'll get guidance on when you can do that and when it should be the complete removal of the restoration. Many times if we see caries extending under an existing restoration, we have to keep removing the restoration until we see sound, healthy dentin. Here's our cavity preparation. I've prepared this using a 35 inverted cone burr. You can see my beveled enamel surface, but my gingival surface is at right angles. You You can see that the preparation design was defined by the composite that was originally there and the extent of the composite of the caries. I etch and rinse. I dry. I moisturize the dentin, place the adhesive. I air thin the adhesive. I light cure the adhesive. I place my composite. In this case, it's still less than 2 millimeters in depth, so I place it in one increment. I then finish and polish it using the techniques we've previously described. And you can see the appearance of the gingival tissue after we've removed and replaced this restoration with a nanohybrid composite resin. There are certain specific considerations when we're choosing restorative materials for the choice of glass ionomer over composite, and that's been described in your decision-making lecture module on Class 5 lesions and restoration. When do you use a composite and when you use a glass ionomer? The glass ionomer we use in clinic for restoring Class 5 carious lesions and non-carious cervical lesions when appropriate is Fuji 2LC Light Cure, which is a resin-modified glass ionomer. It has an acid-base primary setting reaction, like all glass ionomers, but it also has a 10% light-cured resin. It gives us fluoride release, and it's self-adhesive with ionic bonding to the calcium in the tooth. We never acid etch resin-modified glass ionomer preparations. We do use a cavity cleanser, a 10% polyacrylic acid, that cleans the cavity preparation. We mix the capsule on a triturator. The applicator that we use then syringes the glass ionomer into the tooth preparation, and when you're first using this in clinic, ask for some help from the faculty member when you're doing this for the first time. So we're looking at our applicator gun, and the button on top of the applicator gun resets the plunger so you can place the capsule. There are shades available for the glass ionomer. The glass ionomer is not as aesthetic as composite. The capsule itself has a tip built in, and we mix it on a triturator. In order to use any of these capsules, we're going to activate them by pressing them down on a bench top surface. When we've pressed it down and it's in, we then insert the capsule in the applicator gun. We then do one click to make sure the capsule is fully activated. We take the capsule out of the gun by releasing the plunger tip, and then we mix it on the with the triturator. So I'll repeat that. We place it on a benchtop flat surface to push the plunger directly into the capsule so it's flush. We take the capsule and we put it in the applicator gun and click it once to further make sure the plunger is activated and breaking the membrane barrier to allow the resin liquid, liquid for the glass ionomer, to be available to be mixed with the powder. We take it out of the gun by releasing the plunger, and then we mix it on the triturator for 10 seconds. We've actually activated the capsule. We then mix it on the triturator for 10 seconds with the top open. Once it's mixed, we then will place it into the gun for application. So we've described that our preparation design uses a 330 or a 35 inverted cone burr. For this case, we're going to be restoring root caries on a patient that has xerostomia due to Sjögren's syndrome. We're going to be restoring caries on both 11 and 12, and you can see number 13 is going to need a restoration in the future. We're going to use a gingival retraction clamp, retracting the soft tissue. In this case, the clamp's been modified. You can see that the original clamp had an occlusal aspect, and now it's been bent so that we can place it on the root surface. In a clinical practice, when using the dam, you'll have modified 212 clamps. We've placed it on tooth number 12. with the gingival retraction clamp. We prepare the tooth with a 330 or a 35 inverted cone burr, and it may be necessary to use a number 2 round burr to remove the additional caries. We're doing the whole preparation with a slow speed, not with an air water spray high speed. We can see where we're doing, and we're being minimally invasive to remove the caries by being able to see what we're doing, preparing it dry. We then, after the cavity preparation, we use a cavity conditioner, 10% polyacrylic acid, applying it for 10 seconds. We never use phosphoric acid with glass ionomers. We then rinse off the cavity cleanser and we blot it dry. We do not desiccate the dentin surface. The dentin surface will be slightly moist. Notice we do not bevel the enamel surface for a glass ionomer. We do not bevel the enamel surface. Composite we do, glass ionomer we don't. I then place my resin-modified glass ionomer, my Fuji 2LC, into the cavity preparation. I can use a clear Class 5 matrix available in Prep Dispense, or we can adapt it using our Explorer. We then have the light at right angles as close as possible to the tooth, and we light cure for 20 to 30 seconds. Even without light curing, this material will set. Our finishing and polishing is the same as we would do for a composite resin. Gross excess with a finishing diamond, finishing burr, followed by my margination with my medium and coarse discs on the enamel margin, and then using the enhanced polisher. And in fact, we can then use a composite polishing paste if we desire. So our final polish in this case was done with the enhanced cup shape. We don't need a high luster. In fact, it's very hard to get a high luster on these resin-modified glass ionomers because the glass ionomer filler particles are much coarser glasses than what we use with nanohybrid composites. You can see the upper right-hand side, the carious lesions before the preparation and after restoration. Glass ionomer, resin-modified glass ionomer, is slightly more opaque looking than composite. You've been viewing and listening to Anterior Aesthetic Preparations and Restorations, Module A, the Class 5 Preparation and Restoration.